Welcome to Aim in Practice podcast, where we dive into the fascinating world of integrative and complementary medicine, and of course, its real-world applications. I'm your host, Dr. Jess Reynolds, and today we have a truly inspiring guest, Terra Nicolle. Now, Terra is an expert in manual therapy and education with a wealth of experience working with special populations, both in her local practice and across the globe. So in today's episode, we cover a very wide range of important topics, which include the transformative power of small, caring gestures in healthcare and how they really do set you apart as a practitioner, exercises and techniques to maintain the frontline tension and improve overall health, the intriguing connection between scoliosis in mothers and their babies, and how this can impact early development, as well as tailored approaches to yoga for hypermobile individuals and the importance of strengthening over stretching. So now let's dive into this conversation with Terra and explore these powerful insights. You might already be familiar with the name, but if this is new to you, Jane is a PIP-EDA or PIPEDA compliant clinic management software and EMR, and the sponsor of today's show. Chasing down patients or clients for important information, well, it isn't anybody's idea of a good time, especially when there are forms to be filled, payments to be processed, and consents to be collected. That's why Jane has designed a user-friendly online intake form so you can gather all this information and anything else you need ahead of the appointment, whether that's health history, insurance details, or credit card information to keep on file. Jane will even send a friendly reminder 24 hours before the patient's appointment if they haven't completed their intake form yet, saving you from having to manually follow up. To see Jane in action, click the link in the show notes to book a personalized demo, or if you're ready to get started, you can use the code AIM1MO at the time of sign up for a 1-month grace period applied to your new account. Well, Terra, hey, I'm really happy to chat with you today, and I figure we should just jump into our conversation. And I'm going to start a little different than I usually do, and that's usually I'm like, hey, what's the story? What got you into this? But what I'm really curious about for you is what's coming up next, because I know you got some pretty exciting things planned for this month. So let's jump into that. What are you up to?
Awesome. Well, thanks again, Jess, for having me here. I'm really always happy and excited to talk to other therapists and to let them know what's possible. We get kind of stuck behind that mold of what we think a massage therapist or somebody in the therapeutic industry can do, and only what can be done in our community. So I'm actually heading off on August the 13th to Uganda, and there I'm going to be working in Outback Hospital, midwifery clinic, and then I'm going to be doing some education for some special needs orphanages. So just giving them some hands-on techniques and awareness of things that they could be doing with the kids to get them up off the floor. And then in November, I'm going to be in Nigeria. And in Nigeria, I'm going to be working in a rectocele clinic. And they specifically work with just prolapses of all sorts. And there, again, I'm going to be giving pre and post education and manual therapy tips for things that they could be doing to have more successful outcomes. And so, yeah, that's what I have coming up this year. Next year, I plan on going back to Mukingi. I've been going there for 7 years. And there I work in a bush hospital again, giving education to midwives and whoever's doing the lactation training or breastfeeding education and physios. Yeah. Working
Wow.
with CP patients. Yeah.
That is really cool, and I'm looking forward to diving into the intricate details of that. But I want to reflect for a moment just on what you started by this conversation by saying, like, there's so much more we can do in this field as practitioners, and we tend to get kind of like narrowed into what our general city does. Like, what is our province or our city or our state? What do they think a massage therapist should be? And then that's kind of what we paint ourselves into the corner as. But as you were describing this adventure going on, what popped into my mind was James Syriax, the guy who came up with Syriax friction and basically the modern father of orthopedic assessment. And part of the reason he developed the orthopedic assessment that basically every massage therapist and osteopath practices these days is because he went to Africa and then realized, like, hey, they don't have x-rays. They don't have access to all of these assessment, like, imaging techniques. So what can we do manually without access to a bunch of technology to really help identify what's going wrong with our clients? So it's really cool. To me, I got this like grassroots full circle vibe hearing you describe what you're going to be doing there.
Yeah, I mean, exactly what you said. They don't have access to all the technical gadgets and diagnostics that we have here in the Western world. So being able to, which we are highly skilled with our hands and our eyes. So being able to see and assess things that are happening without any tools. And then just in general, manual therapy techniques, moving fluids, um, creating health back into tissues. What a huge difference we can make. There too, they're not stuck in the frame of a healing protocol needs to look a certain way. And so there we can use their brains and their sensory perception of what's happening to our benefits. So
Mhm.
in showing them that something can move, they move it. Where here I find when I am dealing with patients, encouraging them to move is really hard. But there, if I simply, because even sometimes uh, the inability to articulate, right, with treatment. I'm talking through translators. So there, I really am just using hands on. I'm touching and I can sense that there's pain there. I look at them. We recognize together there's pain. I show them with my hands. I continue to hold or whatever I'm doing. And as the pain diminishes, just like any good therapist, I can feel it. So as I'm recognizing with their eyes that the pain is diminishing, now I've established trust. And
Mhm.
so with them feeling the pain diminishing, usually they're more apt to get up and start moving, which is going to facilitate healing more quickly. We know this. Um, Whereas here I find people are more prone to, they don't want to feel too much. So covering things up with lotions or um, painkillers or not moving is actually how most of our patients, I'm not going to say all, because some people are great about getting up and moving, but most of our patients here. So here they rely more heavily on what is that diagnostic telling me? And then I can only progress as I'm having it recorded as progressing. Whereas there, we have nothing but our hands to tell us this shouldn't move or we should be moving. And I feel that we are able to give them more tools to help themselves
Hmm.
um, as opposed to here.
Yeah, I really appreciate that. And what I'm thinking about too is how strongly clients in the West are embedded and entrenched in the Western medical model. Now, I'm not about to bash the Western medical model. Lord knows it has saved my life many a time. Lots of value there, but what I find interesting is very similar to what you're saying. Is a lot of the clients they are stuck and entrenched in this model of uh, doctor, tell me, how long is it going to be for this to be better? And the doctor looks in the textbook and says, it takes 6 to 8 weeks for a bone to go through the healing process. So around 6 weeks from now, you should start to feel better. And then that puts this idea into the mind of the client. Whereas what I'm hearing you say, correct me if I'm wrong, where you're going to be working in Africa is there's not like these standardized models. It's like, we're going to do what we need to do to make you feel better. And the fact is, you got a life. So when it starts to feel better, pay attention, go about your life and continue moving. So it seems like there's less expectation that is both helping and hindering, but in this conversation, hindering the overall process. Does that track? Is that about it?
Yeah, I mean, there as well, time is here, we measure it. We wear watches, we have
Mm-hmm.
clocks. There, if we cast something, we're hoping that they remember to come back.
Mm-hmm.
We're hoping that they remember within a certain time frame to come back to have it removed. So being able to use tools like tape, I take tape there, kinese tape, being able to have tools or just wrapping. We do a lot of binding. Um, being able to have something that they can simply take off is a good idea. So yes, I think here we go very strictly by a time frame. Where there, they innately have to pay attention to their bodies and move forward when they're feeling better. Yeah.
Hmm. And I'm
Yeah,
thinking
and
scope of
manual
practice too. Oh,
therapists,
sorry.
we have so many skills that
Yeah.
because we're not held by um, symptomology, right? We're not held by a disease process. Instead, we're just looking at how can we how can we assist your body in healing itself. So
Mm.
I feel like because our tools are just our hands and our brains, um, how easy it is to give those skills to someone else.
Hmm. I really like that. Is the way we facilitate health is very much in providing our clients with the tools so they could do it themselves. Like we do the things, we make the adjustments, we kind of set the system in on track, and at that point in time, it's like, okay, now it's up to you. You facilitate the rest of your own healing. And I'm curious when it comes to like obviously when you're in the bush, you're not thinking to yourself, well, I got to stay well within my scope of practice so nobody tattles on me and I get in trouble from these. You're probably not thinking, I'm imagining, right? So I'm curious about the techniques and the skills that you use every single day in your practice in the West. How do those translate? Is it like a direct translation, or is it like you do the skills that you do, but then there's a couple other things you do that just wouldn't work in Canada?
Um, I think it depends on the circumstance and
Okay.
what I'm doing. I do feel that a lot of what I learned there translates quite well over here because I do some work that's um, outside of what a massage therapist would do here. I do feel that it gives me a bigger perspective when I'm
Mhm.
treating my patients here, that I recognize more quickly when we need to refer, when there needs to be other interventions as well. And so I'm always of the boat that the more eyes on a patient, the better the patient's healing is going to be because you can't be all things to every
Mhm.
patient. But what I learned there has translated here insofar as it's definitely given me a confidence in yeah, in that ability to notice when there needs to be more. And I don't feel that that steps outside of my scope of practice, but
Mhm.
very much I think that it enables me to have or to give my patients confidence in knowing that their well-being is at the forefront of everything that I do.
Right. Right. That makes sense. That makes sense.
Mhm.
Now, as you go through this adventure, you mentioned like quite a number of different I suppose, modalities, right? You're going to be working at a midwifery clinic and you're going to be doing a herniation clinic. And there's a bunch of these different spaces that you're going to be in. And what I'm curious about is within this adventure, is there any in particular that you're just like, this is my jam? Like, this is the one that I really enjoy? Or is it all just kind of like, everything's amazing?
Yeah. I think of everything that I like to do. I like to work with children best, um,
Mm,
and especially babies, because being able to set them off with the best start is very fulfilling.
mm,
Uh, Also, because in when I go and help in these countries, those are the ones that if they don't get the help, they just don't thrive. And so, and it's the smallest changes that need to be made um, that can make the biggest change. I also just um, I love the excitement of no borders, of having to come up with ideas outside of the box. I mean, a couple years ago, where I go, they don't have any braces for patients with cerebral palsy, and they have a lot of cases of cerebral palsy, um, not the degenerative cerebral palsy, but the cerebral palsy from birth trauma. And so we had a lot of children that because of that, weren't hitting milestones, weren't crawling, weren't walking. And if you can't get up off the ground, I mean, I what kind of a life is that? So I had fun trying to figure out with some of the men that work at the hospital how to make braces out of PCV pipe,
Mm.
PCV pipe, cotton, and elbows, and straps, Velcro straps. So I think, and I am so fortunate as well in the connections, and we all have them. We all have a dentist here in Canada or wherever you are. We all have a doctor. Um, if you're in the therapy realm, you treat other therapists. So we have a wealth of information. So I love the fact that I can call back to Canada. I can call a friend and be like, you know what? This is what I'm seeing right now. I'm going to send you a couple pictures. We don't have any supplies. So what would you do?
Cool.
And, at the beginning when I would call, they'd be like, don't hold me to anything, but I think I'd take the honey off those burns. And I'm like, perfect. Just knowing that saved a lot of children from losing
Mm.
limbs, from, um, you know, gangrene. So
Right.
it's like these small things that here we don't think anything of. Those small things can help change and save lives. I have a doctor right now that's sending me with boxes of erythromycin, the eye drops for the newborns. And it's like that is going to stave off infections and save hundreds, if not thousands, of eyeballs in brand new babies. And
Mm.
yeah, it costs them nothing. Um, they're simply they were samples that were given, but each sample can do 2 to 3 babies, right? It's like small things that we don't think anything of. They can make
Mhm.
toothbrushes. Um, I just picked up, my dentist is amazing. He ordered me from his supplier the samples that they hand out, 200 children's toothbrushes, toothpaste, and floss. I
Mm.
mean, it's going to change lives.
Right. So is that what you mean when you say, help children? It sounds like there's a lot of different things that you're doing, bringing eye drops, bringing the toothbrushes. Do you do any hands-on work with the kids?
Yes. Oh, absolutely. So primarily that's what my practice is here. I
Yeah,
do
yeah.
pediatrics. I see babies. I see moms. So I teach a couple courses on uterine lie, on just that would take us a whole other way. But in talking about like scoliosis and hypermobility and how the changing the tension on the ligaments in the pelvis changes the tension on the uterine lie, which then allows the baby in utero to develop with a spine with the least amount of compression, or
Mhm.
um, a lot of times like torticollis, or some of these breech baby is just caused by babies going to put their head into the softest place when they're in the pelvis. So if the pelvis itself isn't square or doesn't have enough room in it, baby's head is going to be, up under the rib cage. And so when we take tension off those ligaments, then we allow baby to move on its own. His baby is super smart.
Mm.
they're they're always looking for the least amount of tension when they're in the bag, and that's what helps them to develop. So what here in Canada, I see the mom all the way through her pregnancy, and then as soon as the baby's born, especially if there's been a scoliosis or if the mom's hypermobile, I'll see her afterwards to close the pelvis, make sure that there's enough tension on it, and all of that can be done externally. I There's no internal work done there. And then I show her how to bind, the exercises that she needs to do to close her linea alba to help so that she doesn't have constipation or bladder issues right after birth. And then I see baby and make sure that, you know, when babies are born, the jaw is actually has a symphysis. And so that allows it to fold as it comes through the birth canal. And we hope that as baby's born and they get that good twist coming out, that this bone pops back symmetrically. But sometimes it'll pop back on an odd angle, or if there's any jaw tightness at all in through the neck, the the baby is unable to open. They're very snappy. Uh, they can't latch, and so then there should never be pain with breastfeeding, but mom will hear from her providers, well, until your nipples toughen up. And so everybody keeps missing that there's a real problem. And right now we talk a lot about tongue ties, but there's bigger issues than tongue ties. There's also, which dentists are very good now at facilitating, sending babies through to somebody doesn't like massage therapist, osteopath, chiropractor, physio, somebody to release some of the tension. I mean, trauma of birth is just as much for the child as for the mother. And then, so I would facilitate making sure that any tension that's there that might be impeding baby's ability to breastfeed and thrive, if that's what the mom's, if that's what the hope of the mother is. I mean, even to suck on a bottle, baby still needs to be able to form a latch, to be able to sleep, to have the bones of the face push out properly, to not impede hearing, uh, even brain development, right? The bones of the head need a certain amount of compression and pressure that the tongue has to facilitate by pushing into the hard palate. So these are some of the things that I just make sure at the beginning that parents are set up right, baby's nursing well, or feeding off the bottle, whatever's happening with that. And then walking them through, making sure babies are hitting milestones and that developmentally, everything is going well. I mean, yeah, we just know so much more now than we ever knew before.
Mm-hmm. Mm-hmm. Where
So
did you
yeah,
learn all
I love
this?
that. But I also love my scoliosis patients and hypermobility because I feel like nobody's treating or helping them properly either. And so
Yeah.
that's a whole other demographic that seems to be really filling. I have two other practitioners here really filling our practice because nobody is treating them properly.
Hmm.
Yeah.
What does properly mean in this case?
Well, with a scoliosis is not treating them bilaterally. So as a massage therapist, we go in and a lot of times, because a lot of us have taken trigger point therapy, everything that we learn when we leave school, we're just a general practitioner. So everything that we learn is bilateral. We do one side, we do the other side, everything is one side to the other. We're not really looking at why is there a difference in asymmetry. Is in a scoliotic patient, that difference is tightness on both sides, tightness on the short side, tightness on the long side. If I keep treating it bilaterally, I keep making the shorter side tighter, the long side more stretched. So I'm actually creating the torsion and distortion in the body. I'm enabling the body to continue to move into its shortest, tightest position, which that's what our body naturally does so that it doesn't have to work so hard. But in a scoliotic patient, it's driving the curve further into the body, which we know we're more than just what's on the surface. So it's impeding the work of our organs inside. It's changing the pressure within our sinus cavities. It's impeding pressure or putting more pressure on the heart. It's restricting motion of the lungs. There's so many things. So if we understand better that when a person with scoliosis comes to me, what I want to do is create balance in that body. I only want to release the short, tight sides. I don't want to massage their big convexity right rib cage with the one trigger point that they keep coming in for because I'm driving the the lower quadrant into a tighter curve, and I'm now affecting low back and sacrum and pelvic floor.
Right, right, right. I mean, follows the classic principle of Rolfing, where it is, it ain't, right? And on that note, I'm kind of curious because between what you just described with working with the skull bones of infants as well as addressing these very specific issues in scoliosis, and you mentioned it, this stuff isn't taught in school, and I'm pretty deep in the continuing education world, and I've been in it for quite a long time, and this stuff isn't really talked about at all in continuing education with a few very specifics maybe. So I'm curious about that process. Is how did you learn all this stuff? Because it's pretty intricate, pretty detailed, and shockingly specific.
Yeah. Well, I think it was the demographic that I was seeing, because I deal with moms and babies with latching issues, I was noticing that every mom that comes in with a baby with a latching issue has a scoliosis. And it's not
Really?
every mom, it's the ones I was seeing that had issues. So then I was like,
So wait,
I need
I
to
need to
dig
interrupt you for a
further.
second because I need to make sure I'm getting this clear. So what I'm hearing you say is when you would have a mom bring her baby in with latching issues, you found that there was a direct correlation between an infant with issues and the mother having scoliosis.
Yes.
Wow, that is an interesting connection. Okay, sorry for interrupting, but I wanted to make
No,
sure I
that's
understood that
okay.
correctly.
So then I started talking to pediatricians, and um, just in that I was noticing that the patients that they were sending me, they all had a slight scoliosis. But what I started to notice is everybody was like, oh, a scoliosis. Like it was something new. And I was like, it's very obvious that this person has a scoliosis. And it was not being talked about. And so it was almost as if, unless the patient presented with a sore back, or issues with the back or the spine, nobody was looking at their back. And it was unbelievable to me that they were brushing off mom's back pain as just being, well, she just had a baby. But I'm like, but she's always had back pain. This just didn't start with her pregnancy. And she has a scoliosis. And so we know that the uterus attaches to ligaments that attach to the pelvic bowl. If there's a scoliosis, we know that there's going to be an imbalance within the ligaments of the pelvic bowl, which is then going to cause an imbalance within the uterine lie. And then every baby that I see that has a latching issue, that has a mom that has a scoliosis, depending on the birth order of the baby. So if it's her first baby, the curve is the exact same as hers, the exact same. If it's a second time baby, the curve mirrors hers. So it's the opposite, but it's still a curve. And then the third baby would have a distortion of the curves. And then every baby thereafter would have some, um, either some part of the curve, but then if she had like four children, suddenly she'd have no curve. And so I knew that it was the tension on the bag that was changing the way the spines were forming. And then I have one mom that has six babies.
Yeah.
So, and she has a scoliosis and she's hypermobile, which again, they seem to go hand in hand. If you're hypermobile, the chances are you'll have a scoliosis because of the lack of tensile strength. And that's a whole other thing on its own. But I specialize in hypermobility as well. But the lack of tension on the tendons, then the ligaments must take up the slack. So the ligaments become too tight, because they become fibrotic, because something has to hold you together. And if the tendons aren't creating the right amount of space or strength over a joint, then the tendons will become fibrotic and take over that tension. But then that distorts the amount of pressure or compression, and it causes over time a scoliosis. So
Okay.
it's like, at what point does the scoliosis become? If the baby's born and there's already a spinal deviation,
And it's spinal
if there's
deviation in the mom or the baby?
in the baby. So
Okay,
the
yes.
baby's born and it already has the spinal trait of the mom. If it doesn't have the rib head articulation, so do you know the rib head articulation for scoliosis?
Mhm.
Okay. So if they don't have the rib head articulation, which is the convexity on one side and the concavity, so the oblique rib cage on the other side. So if that has already formed, if the rib heads have formed to the spine, we really can't change then at that point the curve or the beginning of the curve in the spine. But we can, by softening the curve as the baby develops and grows, we can allow the muscles to grow the same length bilaterally by taking the tension off the curves. Because now the bundles are growing symmetrically. If you leave them on their own, they'll be asymmetrical. They'll have a short trap on one side, a longer trap on the other side, because the frame denotes the development of the muscles based on the pull of the muscles to the frame. Does that make sense?
Yeah,
So I
yeah.
often
So let
say
me
it's
make
like,
sure I got this. So we've got this connection where if mom has scoliosis, then baby is born with baby one is born with scoliosis that matches mom's scoliosis.
Yeah.
So we're clear in the fact that the pre-existing condition is mom has scoliosis. And what I want to make clear about that before I summarize the rest of it is, uh, what is the likelihood that mom didn't have scoliosis, but then during the fetal development phase, during gestation, she developed scoliosis? Is that a pattern you see?
Um, no, because not a true scoliosis. So,
Fair.
because a true scoliosis is bony articulation. So the
Mhm.
bone formation is wedged or fixed. It's not something
All
that could have just happened. So
right. So we're talking
there,
structural scoliosis.
yeah, there is
Yeah.
scoliosis that can happen from an injury, from how we repetitively, if I sit and lean on my desk every day, and but even that will cause, as the baby develops, if I sat like this every day for my entire pregnancy, that still is restricting the amount of motion within the bag as baby develops.
Yeah.
So we do know that scoliosis is not genetic, it's not hereditary, but it is familial. So there are some components of it. The genetic component would be the rib head formation, because it could be that the dad has a scoliosis and his was on the rib head formation. I know that's a little bit much to get into, but then there are the chances that if the child had it, the mom may not have an actual scoliosis, right? So you do have to look at the family as well. But because what I'm looking at is latching issues, every mom that comes in has latching issues, has a baby, has a scoliosis, and has a baby with a spinal deviation, which just looks like a really tight C curve in a baby. And then they can't look all C curved. So what ends up happening is that the neck shortens on the opposite side of the C curve so that they make more of an S shape. And that is fixable. That is
Okay.
fixable.
Mm-hmm. Okay.
And
Okay.
even
This is
if you
making
didn't know
sense.
what you were doing, even if you didn't know anything, and your baby was born and it looked like that, and all you did every day was move it to the other side, every day you just said, I'm going to take this little baby and twist it to the other side, you're allowing freedom of motion and movement, which then lessens the likelihood of the spine becoming fibrotic or fixed in a position.
Mhm, mhm. If you work with a mom and she comes in, you notice that she has scoliosis. You're maybe already thinking like, okay, mom has scoliosis. Likelihood child or baby's gonna have scoliosis. Um, I want to make sure I understand that is it possible if you've identified mom has scoliosis to do the appropriate massage where you're working on ligaments to ensure that baby either has minimal or no scoliosis?
Yes,
Hmm.
yes. But I always say we can't change mom. So her body is fixed. The bony articulation is fixed. The muscles have developed asymmetrically in a fixed position. You can't change any of that. But if you take the tension off the bag and change uterine lie, yes, yes, you
Okay.
can. I
Okay.
believe that.
Okay. That's
And
good.
I think that, and I know it's a broad statement, but I think that there's no proof of that, because who would say, well, don't treat me and let's see what happens, right? If
Yeah.
everyone was given the opportunity to go in and get treatment, knowing that it was going to help them, nobody's going to want to be a part of the group that says, pretend on me
Yeah.
and let's see what
Yeah.
happens with my baby. Nobody.
Hmm. Yeah.
So that's why it's hard to make a study, an objective study, I think, measurable, because anything when it comes to women and babies, pregnant women and babies, it's like, yeah, we don't want to play around with that. So we just
No.
make the change and
Yeah.
we see the results. Yeah.
Mhm. I don't want to go on this tangent, but I can't help myself but speak to that fact about how, in science in general, we are adamantly opposed to any study that isn't placebo controlled or following the gold standard of studies. But then with pregnancy, we are 100% okay looking at studies and literature and research that doesn't fall placebo controlled for all the reasons you just explained. I agree with that fully.
Yeah.
But I value that way of doing studies so much that I really wish it would extend to all areas. It's like placebo control, very important, but it turns out the N of one study, shockingly valuable. Anyways, tangent aside, I just wanted to make that point. But we're not. You did mention something that I am very curious about, and this is talking about hypermobility.
Mm,
I would like it if we could talk about this in general, and then maybe tie it back into pregnancy,
yeah.
prenatal. But hypermobility, this is something I see so often in the people I teach. So I largely teach massage therapists, osteopaths, yoga
Yeah.
teachers, to a lesser extent acupuncturists. And it's so interesting because the type of person who goes into this field, again, massage, osteo, yoga, tend to be hypermobile. And this occupation is really damn hard on hypermobility. So, can we
Yeah.
talk hypermobility for a second as somebody who
Yes, I would
specializes in it?
love to. So it's actually one of the things that I teach, because there are just two things that hypermobile people, if they do them, they will live a great life. So the first
Ooh,
one
this
is
is good.
never
This is good.
stretch. Never stretch. For the rest of your life, do not stretch. Every time you stretch, you create instability within your body. It is exhausting for your body to tighten itself back up. 75% of people that have fibromyalgia are hypermobile. And so the reason that they're told that they have fibromyalgia is because of the trigger point that's in the belly of 11 muscles in the body, the stabilizing muscles. In a hypermobile person, those trigger points are the only thing creating tension within that body. When you release them, that body struggles to find its way back to harmony and balance. So never stretch for the rest of your life. And then strengthen. Strengthen. If you just do some kind of strength training. So, does that mean that they can't do massage? So yoga. I'm a yoga teacher, and I'm a yoga teacher of yoga teachers. And this is what I have to say about that. Yoga depends on the intention. So you can stretch or strengthen in yoga depending on where you place your intention. So yoga is still valuable for people that are hypermobile. It's just what they do with it. And they're drawn to it because it fits their body best. We've been watching the Olympics. Have you ever noticed the size of gymnasts? They're all the same size, all of them. They're the same size and they're hypermobile. And both those things fit that sport. And so I think that just like with yoga, we are drawn to the thing that we can achieve more easily. And people want to feel like they're doing something for their bodies. And most people that are hypermobile, weight becomes an issue because when you have a body that's not making enough tension to stoke its own internal fires, the systems themselves become more sluggish. And you can stop eating as a hypermobile person and you will still not lose weight because your body is not making the right amount of tension to burn the fat that it has. And then the lack of tension it then creates in the fat that it lays down, creating a tension under the skin, if that's any um, within the joints themselves. That extra layer of adipose tissue is actually creating tension for you when you have no tension. So your body's not going to give up what it needs for stability. It's a proven fact. It is science that in people that are hypermobile, their amygdala is larger than the amygdala in the average person, and they're just starting to do studies more on hypermobile people. There's in Mount Sinai here in Toronto, there's a whole study being set up. I'm actually sending patients daily. You get free counseling, free like psychosomatic emotional counseling, free physiotherapy because they're trying to understand and gather information from this population that has wholly been missed and misdiagnosed. They have the most chronic pain. Their inability for their body to understand its place in space um, appear to make for a more clumsy person, that's constantly injuring themselves, rolling ankles, um, but the emotional stress, higher levels of depression and mental illness when your body is not making the right amount of tension for it to feel safe within itself.
Hmm. This is a big can of worms that we just opened, apparently, with hypermobility.
Yeah.
I find it to be a very important discussion to have, and I was very pleased to hear you say the two things, because those are the exact two things that I've been preaching on myself. I mean, it's ultimately, I believe it's relatively obvious when you understand the physiology of
Yeah.
hyper and hypermobility. But then there's this issue. There's this issue that arises. And the issue is the fact that, well, hypermobile people, they like doing yoga because it fits their body style. I get it. I love climbing because it fits my body style.
Hmm.
So if somebody came up to me and said, "Hey, listen, I know your favorite thing to do for activity is climbing, but it's really important that you don't do climbing the way that you like to." That's an important distinction right there. The way you like to, because it doesn't fit your body type. So how do you work with like anybody when you say you're hypermobile, don't stretch. But they're like, but stretching is my thing. I love it. It fills me. And they come up with all these reasons, valid reasons,
Yeah.
why stretching is important to them. How do you work with that?
So I explained to them that because their tendons aren't making the right amount of compression over their joints, their ligaments have become too tight. Ligaments are not supposed to be tight. So the ligaments keep telling their brain, I need to stretch. But the more they stretch to loosen up their ligaments, the less tension they make in their tendons, which makes them more prone to injury over time. So that's why the stretch feels good short term, but long term, it's creating a lot of distortion. Then I always show them this. See, when I do this, how good that feels for me? And they're like, yeah. And I said, yeah, but it's not the stretch that I need to do. Because as you can see, look how far I can go. I'm actually just hanging out, but it feels really good because I'm taking my body more into what it likes. And so when I take it more into a position it's stuck in, then I get a sensation of relief, but it's short lived. So then I tell them, I want you to give me 3 weeks. I want you to still do yoga, but I want you to, as you move through the postures, I want you to think about isometrically contracting. It's not that you can't do that stretch. It's just that I want you to isometrically contract everything. Then you can relax and then move on in the pose. So I'm still giving them a little bit of what they like, but I'm also showing them how important the contraction is. But usually all it takes is 3 weeks for their body to start to have more ease, for their mind, incredibly, to have more clarity. Because when your body is struggling to create tension within itself all the time, it's depleting every other system. So you're exhausted all the time. You have no capacity um, for anything else. And I always explain to them that capacity isn't physical. It isn't all physical. It can be just mental capacity. Like I'm starting my day and I'm already at 80%, my cup is full. And so now somebody cuts me off, or like I have no capacity to have room for anything outside of what I'm looking for within that day. And that's just exhausting.
Hmm. Hmm. Yeah, that makes sense. I really appreciate that sentiment and that process. Very similar to the one that I eventually came to, and I like the 3 weeks. I was a little bit more strict. I'm going to try the 3 week things moving forward, but I was a 2 monther. Like, let's do this for 2 months. Let's just try a 2 month trial run where you really focus on strengthening. And the experience that I've had with my clients is if they genuinely commit to that, and they say do the 80/20 principle. 80% of their time in yoga or whatever physical activity is spent strengthening. Cool. Then you can have 20% where you could just go ahead, do your Gumby thing. Fine.
Yeah.
So long as the 80% is still really focused on really making sure that there's the foundation of strength. So yeah, okay. It sounds
Well,
simple, one of those
I
things.
feel like at the 3 week mark, because that's that whole 20 day for a new habit.
Hmm.
I feel like at the
Hmm.
3 week mark, they start to notice a difference. So I just want them to notice. If they can notice, like, oh my gosh, I do feel better. The big thing too is usually if weight loss is something that they've been trying to do and they've been doing cardio and they're doing all these things and they're not losing any weight. If they just follow what I said for the next 3 weeks, and the other point is closing that front line, but we'll talk about that in a second. But if they just follow those 3 weeks, they've already noticed that they've started to lose weight. And it's not in that the scale has moved, but they feel tighter and they feel like their clothes are fitting more differently. So they're noticing that there has been a physical change. And usually that's enough motivation.
Hmm. Okay, I'm curious now. I'm curious. Tell me about this closing the front line.
Yeah, so super important. So people with scoliosis who usually have endometriosis, if it's a woman, endometriosis and PCOS, or if it's a man, will eventually end up over time to have prostate issues. So if that front line is open, because it's not a woman thing, we tend to think of that linea alba, that diastasis opening, as a pregnancy only thing. It's not. I see men with frontline opens, and it's not necessarily that they gained a lot of weight. It's a beer gut, a beer belly. I have gymnasts, bodybuilders, anywhere where there's constant tension on that front line. So that's the linea alba that attaches from the xiphoid process to the pubic bone on either side of the pubic bone. So, in a hypermobile person, remember that all your connective tissue has more play in it than most. So, that front line is all connective tissue, and it is the main attachment for the abdominal muscles, but it also has a fibrotic attachment into transversus abdominis, which is the container. So, transversus, it doesn't have any contractility on its own. When we pull our belly button in toward our spine, we're initiating a motion movement with all our abdominal muscles. Transversus is actually the tight skin on the drum, and it envelops all the way from the front of our body. It encases all the way around, and it wraps into and integrates into QL, psoas. It attaches onto the vertebral body of the lumbar spine. It's responsible for holding our guts in. The linea alba comes on the front of that line, and it creates the tensile strength to pull it all back. And if you think about it, the most easiest way to think about it is we have our spine at the back and our linea alba at the front. And those two things together create the right amount of tension so that our back muscles can move and our abdominals can move. If I lose tension in that front line, my back is going to become rock hard because something has to hold me. If I become too tight in my abdomen, then I have too much mobility in my lumbar spine. So, which is very rare, very, very rare. I have nobody that has a too tight front line. But I'm saying if it was to happen, if you were a gymnast, or not a gymnast, if you were a what can I say? What would even just fold forward all the time? I don't know. Maybe, yeah, maybe somebody that sat at their desk all day and pulled their guts in. I don't know. But that line, the tension that's on it, then creates symmetry for all the muscles that attach to it. If we lose tension on that line, now if it opens below my belly button, the ligament that attaches from my bladder, that attaches to the back of my umbilicus, that holds my bladder up, now has no tension on it. My bladder attaches by ligaments to everything else that's inside my bowl. So now it's all lost the tension and integrity to hold it up. My cervix, the head of my cervix and my uterus, the neck actually fascially attaches onto a false floor that attaches onto my hip bones and pubic bone at the front, and then back to sacrum. If I lose tension on that front line in the lower part, now I've lost tension on all those ligaments. So now I'm more apt to prolapse, um, digestive issues, uh, rectocele. Yeah, I alternate. I have irritable bowel. I alternate between constipation and then diarrhea because my bowels aren't making the right amount of pressure on them. It's a huge issue. If above that line opens up, um, from my belly button to my xiphoid process, now my diaphragm doesn't have the right amount of tension. So I actually had a patient, it kind of crazy. He had a lung that actually came off the lining and pulled up, and they said it was lack of tension on his diaphragm. And he had an umbilical hernia for years that they didn't think was worth repairing. So yeah, that line creates the right amount of tension within our canister, which is all our internal organs, never mind our heart, right? Our heart attaches onto the back of our sternum, but it's actually a floating organ per se inside a bag. And the pressures in that canister then create the right amount of pressure for my heart to do its job. So even my heart doesn't have the right amount of pressure on it. Um, a lot of my everyone that has a scoliosis will say, occasionally I get these weird heart palpitations, a little bit of a cough, and then it goes away. And they've hooked me up to the heart monitor and I'm fine. I'm like, you just don't have the right amount of pressure on your sternum, which is not creating the best environment between the lungs hugging your heart and the sternal pressure on your heart for your heart to be in a space where it has the right amount of pressure on it.
Hmm.
Yeah.
Hmm. So it's
I'm
it's apparent that. Go ahead.
Yeah, I'm gonna say I can't. So one thing I will say is this has just been what I've seen. I mean, I'm not a medical doctor, right? So I'm not a scientist. Um, but when you have every patient and you say to them, "Are you having this sensation?" and they say yes, it's like you have to start at some point putting the dots together. Even a cardiologist that I talked to, that I said this to, he was like, "That makes complete sense."
Mhm.
But it's not something he would investigate because it's not helpful for him.
Yeah, that's it. No, I'm on board with that. I think all of these matter, and that's part of the reason why I love having these discussions is because I get to talk to people like you who have a genuine wealth of experience in which you've seen thousands of patients and been able to put this together. And it sounds like this whole frontline laxity issue is has some pretty profound consequences. I mean, you listed off a lot of them, and I'm curious, what do we do about it?
Yeah, it's super easy to close it. So gentle pelvic tilts will start bringing that line back together. I say in my pregnant patients, it happens quite quickly because the line came apart quite quickly. In my male patients, that line comes back together quite fast. And I believe it's because the difference in the shape of the pelvis. So because their pelvis is more straight, there's actually less pull on that line. So and they seem to be more motivated to do the exercises. I'm not sure but they tend to get the results more quickly. And then, yeah, so I see it in babies with umbilical hernias, that front line, if they have a spinal deviation, that front line will have not come back together smoothly. I also see it in toddlers. If you have a toddler and they can't jump, chances are that front line is still open on them. It seems like such a small thing. Like children should be able to jump. And so if you ask your toddler, jump, and they actually can't bring their feet up off the floor, chances are that front line is open. If you're experiencing toileting issues with them and they're still not training, chances are that front line is open. So in children, we can do like a fake little sit up to cause a contraction to close it because the line is more malleable. In adults, we start with pelvic tilts. So no contraction, just lying flat on a surface with knees bent. And it's just that gentle pelvic rock, low back next to the mat, low back up. Super simple, no contraction. In 2016, Diane Lee put out a study. She's like the guru for pelvic floor worldwide. And up until 2016, she was saying it didn't matter if the front line was closed. And I was like, I don't care if you call it a diastasis or if you call it, because they like to play with words. So a diastasis has to be 3 fingers, but an abdominal separation can be as little as 1 finger. But they're saying if it's a diastasis, it'll cause issues. If it's a 1 finger abdominal separation, there's no issue. But I'm I'm in the camp and now they're coming on board. If there's a separation, there's a separation. So any separation causes a loss of tension, which over time will only exacerbate itself.
Right.
So starting with general pelvic tilts, no contraction, 3 times a day, 15 times. So it's more that you space out and the consistency than the amount. Um, and then once that line has tensile strength to it, then we say start with minimal core exercises. So before the line's closed, no crunches, double leg lifts, or planks. Once the line has been closed, we start doing asymmetrical motion and movements. So crossing over crunches, but again, upper or lower, not together until the line is hard. And then you can go back to your core exercises. There's some great sites out there. Actually, I have an online app. It's called OsteoU, and people can click on it, and all they have to do is put in their email address. They're not going to be spammed. I have no time to put anything in there. So, but it has a bunch of free stuff in there. So it does have like a sequence for closing the line and then what the graduated exercises would be. But there's other people that have it as well. Trista Zinn has a site that does it. The Bell method, Belle. She has a great site with one of her bubbles is just diastasis repair. I highly recommend whether you've had a baby or not. If you have a frontline separation, those exercises are great.
Hmm. That's Osteo U or Osteo University. I'm going to put the
OsteoU
links
is
in.
my app. I'll send it to you.
Okay.
It's
Yeah, I'll
free.
make sure it's in the link in the description so
Yeah.
people could check that out because that sounds like an invaluable resource.
Oh, thank you.
Yeah. And I'm curious now. We chatting for nearly an hour, and I suspect we could talk for about another 5 hours. But you're going to Africa, you're doing this, but you also teach, and you're pretty prolific in the teaching world. And I'm curious, what's like the dream? What's Tara's dream? If you, as a practitioner, an instructor, and a philanthropist, and somebody who's deeply embedded in this world of manual medicine, if you could wave your magic wand and have something change or happen in our industry, what would it be?
Um, Well, I think I see it already happening. So, what I would like to see is more people excited about developing greater skill sets for specialized populations.
Mm,
There are a lot of people just doing massage. And it's invaluable. I often say when I speak at conferences, a lot of people are doing the work that I'm already doing. They just don't know what they're doing, which is exciting for me. But my whole goal in what I do and what I'm hoping to see is I just want to get into as many forums as I can and share as much of the education as I am because if people could step off from what I've learned and then move forward, then we actually move forward. If I keep waiting for everyone to get to the point that I'm at, I mean, I'm 57. What a waste of time. So I, for me, it's never been about selling courses, which I'm horrible at doing. And I've realized that it's better for me to go and teach courses for other people because they've already set that up and got that running. My whole goal is to share as much information as I can so that I can have so many other people be my hands and feet. And I feel that if if we just get excited about what's before us and look at the populations that we're seeing and then just how can I serve you better? And I can say sites like yourself, education sites, continuing education sites are invaluable. And even if you just take away one small piece and you can implement it, um, yeah, how exciting that is for us as educators that people are listening.
yeah, that's
Yeah.
beautiful. Thank you. I love that message. And I have one final question for you, and it's the same
Okay.
question I ask virtually everybody. It's my closing question. So, in your experience, both as a practitioner as well as somebody who has received a lot of treatments, what do you think makes a practitioner successful?
You know what? That is so interesting because today I went and had my eyebrows done. And the last time I went to that place, at the end, after the girl did my eyebrows, she gave me a face massage, and I loved it. Loved it. And so I tipped her like an extra 20 bucks. It was only $20 to get my eyebrows done, but I was like, that was amazing. So this time I went back to that same place because I was excited about the face massage. And I didn't care who did it for me at that place because I figured if she did it, they all did it. But I went in, this girl just did my eyebrows. At the end of it, I was like sitting there waiting for the face massage. And she tapped me on the shoulder, like, you're done. And I was like, oh. So I got up, so I tipped her and I left. And I was thinking about it when I drove home because I believe that that's part of every business. And I thought, all she had to do was rub my forehead a little bit, right? Like all she had to do was just touch, um, just do something that showed like, oh, I'm caring, right? And I believe that what sets practitioners apart are those small extra things that are like, um, I was even thinking of that today that everyone here, I'm going to tell them, I'm going to get some lemon oil. And I'm going to say at the end of your treatment, every treatment, I just want you to rub some lemon oil in your hands and just hold it over their eyes for a second and ask them to take a couple deep breaths in. Because when you leave them with something that feels like you're resetting their nervous system, um, I think that'll really set you apart. Yeah, something you have to do something extra that sets you apart if you want to be successful because otherwise there's a million people out there doing the same thing. Yeah.
Hmm. I love it. That's great.
Now
Thank
you
you.
know I got my eyebrows done before.
Tara, this has been a fantastic conversation. I'm really grateful for this. I learned a ton, and I'm sure everybody who's
Awesome.
listening to this also learned a ton. You are a fountain of knowledge. So,
Thank
how can people keep track of what you're doing as far as if you're going to be speaking anywhere, courses? Of course, we'll put the link to that app in the show notes. But how else could
you.
people get in touch?
Well, I'm hoping to do some work with you at some point,
Yeah.
Jess. I'm excited
Oh,
about that.
yes.
But
Yeah, me too.
um, yeah, I speak at a lot of conferences. So the best place to see where I'm going to be speaking or what I'm doing or what I'm up to is follow me on my Instagram account, Terra Therapeutics. It's in the show notes. That's the best place to see what I'm doing. On my OsteoU site, hopefully I'll upload some more. There's a ton of free stuff on there for hypermobile, hypomobile pelvic floors, how to spring a rib cage. Uh, yeah, I do a short rant on everything hypermobility and scoliosis. And yeah, and ask me questions. I learn when people post questions, especially when I don't know the answer. I'm like,
Mm,
that was a great question. I need to know that answer. So, yeah, whet my knowledge and hopefully I inspired and got some other people excited about what we can do. There's a lot of
yeah,
possibilities.
there sure are. That is great. Thank you so much, Tara. I really appreciate it.
Thanks, Jess.